Respected judges and my dear colleagues, today I, Dr. Chenchulakshmi, am presenting to you my study titled The Reliability of Simple Clinical Tools in Diagnosing the Conundrum of Laryngopharyngeal Reflux Disease. Coming to the introduction, so laryngopharyngeal reflux disease is a very distinct entity separate from GERD, wherein it occurs because of the exposure of the laryngeal mucosa and the respiratory epithelium to gastric irritants. The LPR is basically because of backflow of gastric content up to the level of the glottis and the pharynx above the level of the upper esophageal sphincter. This LPR diagnosis very commonly gets mixed or fogged because of non-specific presenting symptoms. Sometimes it appears to be as if it's upper respiratory tract infection, sometimes similar to angina pectoris, many times similar to that of asthma, sometimes having just hoarseness of voice, or sometimes even as if an allergy. There is no specific investigation available to confirm the diagnosis of laryngopharyngeal disease. At the same time, the researches that have been done to identify this within our country are also very less. The aim of our study was to assess the correlation between the clinical symptoms and the laryngoscopic findings in cases of reflux laryngitis by utilizing two scores, the reflux symptom index and the reflux findings score, and then their applicability together as a reliable diagnostic tool for diagnosing LPR. So coming to the materials and methodology, we had 75 patients included in the single blinded study, all of whom were given the reflux symptom index score questionnaire. This RSI was developed by Belfsy et al. And it has facilitated the clinical diagnosis with the help of a score of more than 13 out of a maximum of 45 points, wherein symptoms such as hoarseness of voice, lump in the throat, heartburn, repeated clearing, post-nasal drip, difficulty in swallowing, coughing on lying down, and troublesome cough and choking sensation are all included. After which, the patients who had a high score and a positive LPR were underwent laryngoscopic examination using a fiber optic endoscope. Then the laryngoscopic changes of each of these patients was then graded using the reflux finding score, wherein a score of more than 7 out of 26 was considered to be significant. We then analyzed these results with the help of ANOVA test, chi-square test, and student T test. So coming to the results, the patients with abnormal reflux finding score studied in relation to those with a high reflux symptom index showed to have a positive or a significant correlation of p-value less than 0.05. The flexible laryngoscopic findings have been shown in these images. One shows arytenoid hypertrophy bilaterally with a congestion, which is very common, seen in about 77.3% of the patients. Diagram 2 shows us a collection of sputum found in about 42% of our patients. Diagram 3 shows us posterior commissure hypertrophy found in 26.6% of the patients. And lastly, we can see bilateral ventricular fold hypertrophy with a generalized congestion, which is found in about 75% of the patients. The mean RFS was around 10.65 with a mean RSI of 0.05. So we can see both of them were raised. And in most patients who had a raised reflux symptom index, they ended up having positive features in the reflux finding score. So the LPR has been a long diagnostic dilemma requiring comprehensive evaluation of the symptom, frequently overshadowed or misdiagnosed, causing a delay in the treatment as pointed out by several studies already in literature. So in discussion, all the symptoms we found had a significant effect on the vocal cords, and thus we were able to explain the finding of or the symptom of hoarseness of voice. Then most of the patients presented with difficulty in swallowing or a globus pharyngeus sort of picture. This was correlatable to the findings of erythema and posterior commissure hypertrophy. In this manner, we are able to relate the clinical features to the symptoms that the patient presented with. So current research is still being performed to identify several markers like interleukins, carbonic anhydrase, cadherins, and mucins to become definitive diagnostic tests. But until now, most studies show that reflex finding index with a high specificity and sensitivity to diagnose LPR. Coming to the conclusion, we conclude that the reflux symptom index along with the reflux finding score are very simple, quick, reproducible scores, and together they establish a definitive diagnosis of laryngopharyngeal reflux disease, allowing us to begin the treatment immediately for these patients and provide them with a quick respite. In this manner, these two tests can be used together to complement each other as a very reliable clinical tool. These are my references. Thank you.